Welcome to this edition of Inside Cardiology, Cardiovascular Medicine in a nutshell. And today we're discussing about something that is an old molecule but is center stage now, lipoprotein a. Although discovered decades ago, it has been dormant until recently, since we learned that it is important as a predictor and most likely also as a therapeutic target. And here you see what it does. It is pro-atherogenic because of oxidized phospholipids, then fosters foam cell formation, smooth muscle proliferation, monocyte chemoattractant. It's also prothrombotic, activates plasminogen, TFPI, clot permeability goes down, and platelet response goes up. It has this kringle on the side, as well as ApoB, and of course lipoprotein A together with this kringle. And of course the question is this really important? If so, what do the physicians know about it? Do most physicians know about lipoprotein a? Not so much yet. Do they consider it as a risk factor for the patients? Hardly. And then of course question, do they measure lipoprotein a in the patients? Very rarely at the moment. And do those who do know, do they consider the evidence? Not really yet. So please watch how important this is and will be in the near future. First of all, this is the distribution of lipoprotein a plasma levels in healthy populations. It is genetically determined, it runs in families. Therefore, these subjects and individuals, they have cardiovascular disease early on because of this additional risk. You can see it's also ethnicity plays a role. In white individuals, the distribution of lipoprotein is more to the left compared to black individuals. Also Southeast Asians and other ethnicities have higher levels of lipoprotein a. And what does it do? Well, first of all, is, as you can see in the plot here, it increases risk dose dependently with the increase in plasma levels of the lipoprotein. It is associated with cardiovascular events in general, such as myocardial infarction in particular, also with aortic stenosis, and therefore is very important to know about for cardiologists. Now, aortic stenosis is the first one. You can see here that this develops over decades, and we have never really thought about the molecular mechanisms a lot, which is put in a valve either by the surgeons or now with TAVI through cardiologists that are in this field at the very late stage of the disease process, where often the myocardium already took some damage from it. So basically this concept would be to prevent rather than to treat aortic stenosis. And lipoprotein is important here. First of all, there is a genetic association with valvular calcification and aortic stenosis. There is a SNP in the lipoprotein a, locus RS 104-55872, that reached genome-wide significance for the presence of aortic valve calcification with an odds ratio of 2.05. So that's the genetics. Then of course the question is it causal in nature? And if we don't have a drug to prove it, we do Mendelian randomization studies where we compare a SNP in the lipoprotein that I just mentioned compared to patients who do not have this SNP. So rather than a treatment, we genetically randomize patients, and here the odds ratio per allele for the presence of aortic stenosis is 2.05, so demonstrating that high Lp(a) levels are indeed causally involved in the development of aortic stenosis. Now, what can we do to treat lipoprotein a plasma levels, be it to prevent infarction or premature death or an aortic stenosis or both? Estrogen for women in postmenopause have some effect. Niacin has an effect, but it induces flushes and is not very popular at all among patients. The PCSK9 antibodies or siRNA like inclisiran, they lower it a little bit by 15-20%. So that's what we have currently at hand. But what's coming are antisense oligonucleotides and siRNAs to actually really prevent the formation of this protein in the liver. And of course, in the liver, we can provide any antisense oligonucleotide or an siRNA specifically into this very tissue due to the fact that we have this azologlycoprotein receptor. And if you take a double-stranded RNA and put the GalNAc, N-acetylglycosamine, on it, then you specifically bind to this receptor, and you will be able to provide these ASO or siRNA specifically only to hepatocytes where lipoprotein a is formed. And then, of course, you will have an important effect, hopefully. And here is the evidence. This is lipoprotein a levels in cardiovascular patients. And you can see pelacarsen is currently tested in the Horizon lipoprotein a trial. Should be ready by Munich 2026 for presentation. Lowers LP a by 80%. What's upcoming are siRNAs like olpasiran, lowers it by almost completely. Ceralaziran as well. Then lepodisiran as well, and then there is also a small molecule that's less effective, about 2/3 reduction. So clearly we have now tools at hand, and we can summarize lipoprotein a is an important risk factor. You should measure it once in your life, in yourself, but also in your patients. Be aware, particularly in patients that have a myocardial infarction below 50 years of age, and if you have high levels of lipoprotein a in your patient, consider at the moment a PCSK9 inhibitor. That's the only option we have. Lower LDL as much as possible to reduce risk below 1.4 millimoles per liter, and consider a PCSK9 drug to lower it, also lipoprotein A by about 15-20%. And in the future, consider ASOs and siRNAs, and then of course we will be able to address a remaining cardiovascular risk in many of your patients that have the unfortunate genetic propensity to develop high LP a levels. That's it for today. Thank you very much for joining.